be discussing about the global hip registry data trends. So there are various registries: National Joint Registry, Australian Registry, American Joint Registry. So what are joint replacement? Joint replacement are basically relieve the pain, restore the movements, liberate the patient and their family. Patient goes back to work and sports. I think it's an investment of the patient towards his life, towards his quality of life. And we have to see that all the replacement are not the same. All the hips are not same. We have, so for that, how do we assess the prosthesis? They all stems look same, but they are all different. They are used for different purposes. So to decide which stem to be used, we require post-market surveillance, which is called as a registry. So what is the purpose of registry? It's collect the demographic data on joint replacement surgery, provide a mechanism for audit to the hospital and surgeon. It helps to improve our outcomes. So we have to remember that revision is a clear endpoint to the failure, and reducing the revision rate it should be our principal focus. So what are the reasons for failure? Already been discussed the failure of the bone. It can be due to the failure of bone, fracture, loosening of subsidence. It can be due to infection, recurrent dislocations, fracture of the prosthesis, which can occur at the neck, stem or the head and liner, aseptic loosening, limb-leg discrepancies, tweaking, in case ceramic on ceramic, and pain. There are some prosthetic related problems such as design, manufacturing materials, surgeon related, choice of implant which surgeon selects, patient related, patient's activity, and biology, polyethylene variants, metal on metal reactions. So these are so many registries are available. So we are not going through all of them. We are going through the Australian and National Joint Registry of UK. So registry is one of many information that we can use in our decision making process. It is no more or less important than any other data that we may use, and registry tells us what happened but not why. So we have to be very clear about it. We won't be able to find out why this is like that. So these are the total hips done in the Australian General Registry. So in 2020 they have done around 50,000 hip replacement. In National Joint Registry, the UK registry, they have done about 63 to 65,000 hip replacement, and the last one is Sweden, but it is not updated after 2019. We can see the impact of COVID-19 on the hip replacement in 2020. There is sudden dip in the hip replacement. There is around 5 to 0.8% dip in the total hip replacement which were done pre-COVID area. And we can see in the UK, there is almost around 40 to 50% decrease in the hip replacement in the COVID. So incidence and causes of revision if primary diagnosis is osteoarthritis of the hip. This is clearly related to the primary diagnosis if osteoarthritis is there. So what are the incidence and causes of revision? In these cases are first in the National Hip Registry, it's basically because of aseptic loosening, lysis, unexplained pain, infection comes fourth, and in case of Australian registry, the prosthetic dislocation and instability followed by infection and fracture and loosening. So the revision rates are higher in case of neck of femur fracture and anterior approach. There are 5 risk factors for the we have to discuss. The first is age and gender, primary pathology, surgeon experience, fixation of the prosthesis, bearing surface and surgeon port. So age and gender related revision rates or the younger females, most commonly females are mostly revised. The younger females with less than 55 years of age have a higher risk of revision. The older female more than 75 years of age have lower risk of revision. So surgeon experience also matters. So surgeon who is less than 3 years in practice, so we divide them into less than 3 years, 3 to 7 years, and more than 8 years of experience. So according to data, the surgeon with less experience, less than 3 years of experience, have a higher rate of revision rates. So fixation trends. How do we fix the implant? The fixation. The cementless fixation has increased from 51% 2003 to almost 63% in 2020. Hybrid fixation means uncemented cup and cemented stem has been decreased from 33%, 35% to 33% in 2020, and cemented has gone from 14% to 3%. So this is the showing cumulative percentage revision of primary total hip replacement by fixation. So there is no difference in the rate of revision for the cemented compared to the hybrid fixation. Cementless fixation has a higher rate of revision than hybrid in first 3 years. After that, there is no difference. Cementless fixation has a higher rate revision than the cemented fixation for the first. After that, there is no difference in case of more than 75 years. So the outcome with respect to the fixation vary with age, primary diagnosis and the gender. So less than 65 years, there is no difference in the if the primary diagnosis is osteoarthritis. The revision rates are same. The cementless fixation has a higher rate of revision for the patient with more than 75 years age. So for the more than 75 years of age, we should consider at least hybrid or cemented fixation. So why do the cemented stems have a higher rate of failure? So the reason which I thought 80% of us make one cementless stem type work in all our standard primary situation, and some surgeons never use cemented stem. So these are the variety of femur we come across our practice, and this requires a variety of stems. Short uncemented, long uncemented, and the cemented stem. So what is cemented and cementless femoral stem fixation in the THR for the patient older than 75? So for the female patient aged greater than 75 years, primary diagnosis of A, stem philosophy is better than the cemented philosophy is better than the cementless, because this female patient never recovers from the higher early failure rate. Male patient with OA with greater than 475 years, cemented and uncemented stems revision rates are same for all patients, both and female, aged greater more than 75 years. With the diagnosis of fracture neck of femur, the cemented stem has shown a better result than the uncemented stem. So bearing surfaces already been discussed. The ceramic and highly cross-linked polyethylene are less revised than the conventional poly. At 20 years, the cumulative percent revision with the ceramic and ceramic is very less, around 5.8%. So this has been proven given in registries of UK and the Australian registry. So what they have done then, they have done the 4 asset-builder components with large number of both high cross-linked polyethylene and conventional poly. The one which done with the high cross-linked poly have a lesser revision rate. They have a reduction in both lysis and the dislocation. In case of ceramic and ceramic bearing, there is no difference between the metal on highly cross-linked polyethylene greater than 3 years, after which ceramic on highly cross-linked polyethylene is less revised. First 3 years both are same. After 3 years, the ceramic on highly cross-linked polyethylene are less revised. Ceramic on ceramic bearings with larger heads are less revised than the smaller heads. The CPR for the mixed ceramic on ceramic with 36 number head or greater have a 4.4 versus 4.5 years revision rate. So in case of neck of femur fracture, which implants to be used? Bipolar is the least revised in case of partial hip replacement, then the unipolar monoblock or unipolar modular. Cemented stems are least revised in both male and female patient. So head sizes is also important topic. The head sizes of 36 and 38 mm have been combined in analysis. Mixed ceramic heads with sizes less than 28 mm have a higher rate of revision than the 32 mm head. When compared to the 32 mm head sizes, there is no difference in the rate of revision between the 32 and 36 and 38 head sizes. There is no difference in the rate of revision rate between the 36, 38 and more than 40 mm head sizes. At the end of 1 year, the incidence of prosthetic dislocation and instability is around 1.7%. So dual mobility prosthesis currently being popularized by various surgeons. There has been increasing use of this prosthesis. The around 16,000 hips have been recorded in their registry, which is 19.6% since 2019. Basically, they use it for the neck of femur fracture or fail internal location, fail internal fixation. When all the diagnosis means ONE, avian, fracture or the dual mobility prosthesis have been higher rate of revision as compared to the other acetabular prosthesis. But dual mobility prosthesis have a lower rate of revision in cases of compared to in case of neck of femur fracture or the internal fixation or the when it is used for the dislocation. The outcome of the revisions. So we have to analyze the revisions of the known primaries. All the details are available, all the revision, but data is less. So categories of revision, major total means all the process revision is around 40%. Major partial where only acetabular component revised is around 28%. Femoral component revision around 90%. Minor means head or inserts in changes or head or insert only is around 6%. But this is not 100% as a partial THR or infection not included in this, wherein 2-stage or 1-stage revision is done. So what are the outcomes of revision? Minor revisions are higher rate of re-revision, means if done in less than 5 years of primary procedure. So we have to always think before doing any minor revisions early. Minor revision in the case a longer neck, lip liner. So what is the take-home message? The young surgeons have been shown to have higher revision rates. Cement is equal to cementless if less than 65 years. Cemented is best in women more than 75 years. Cement is best for both the genders in case of neck of femur fracture. Highly glossy polyethylene has a less revision rate as compared to the conventional. Larger ceramic heads do better. You should always be aware of the minor revisions. Individual confidential surgeon reports are beneficial. Thank you.